And her grand rounds today is going to be focused on an update on health issues in international adoption. So welcome, Judy.
So thank you for having me today. I'm here to talk about international adoption, and I feel like it's such a small subfield that a lot of times other specialties and other medical professionals don't even know what we do really. So hopefully today you'll get a better understanding of the things that we're doing day to day, kind of the issues that we're facing, including PowerPoint issues. Okay. So the goals today are to describe the trends in international adoption and some of the major changes in the demographics of the children that we're seeing who are being considered for adoption. I want to highlight the children themselves who are coming to the homes in the USA and talk about some of their medical and emotional needs that we're seeing. And it's an opportunity to familiarize ourselves with the updated research and current recommended medical screening for these children. And then hopefully we'll have time just a little bit at the end to talk about some advocacy and ways of thinking to provide for orphans, because there are a lot of children who are not internationally adopted and who are left behind in the orphanage system, and so ways to help them as well. So just a few statistics and trends. The number of international adoptions in the U.S. approached 16,000 in 1998. It peaked at about 23,000 in 2005, and then by 2011 it's back down to 9,319. So you can see it kind of goes up and down, and we'll see a little bit more about some of the trends here. But for 30 plus years until 1995, South Korea had been the major country that had participated in international adoption. But as of 2011, the 5 main countries of origin were China, Ethiopia, Russia, South Korea, and the Ukraine. And that's quite a shift because of some of the things we'll talk about in terms of the histories between these 5 countries and then compared to Korea and what we used to see. So you can see back in the 80s and 90s, it was largely Korea that was the country that had participated. Korea is red here and continues to be a country that participates in international adoption, although we'll talk about some of the trends there. And then as we entered the 90s and then into 2000s, we started to see the other countries like China and Russia becoming bigger countries in terms of participation. In the beginning, we had a lot of concerns. When Dr. Dana Johnson founded the clinic about 25 years ago, there were a lot of concerns about HIV, hepatitis, infectious disease issues, and a lot of the ID folks got involved in international adoption because they were seeing, tropical diseases, parasites, other communicable diseases. And then some AAP Red Book screening guidelines were set. And now adoptions haven't fallen completely off, but they're definitely on the decline, and there's been about a 50% decrease in this time. A few reasons for this is good and bad are an implementation of the Hague Convention on Intercountry Adoption, which is a governmental kind of covenant or agreement that countries need to subscribe to in order to be participating in international adoption these days. And it lays out some good guidelines. The goals are to standardize adoption practices and to decrease child trafficking, which is always a main goal. But there's increased domestic adoption and foster care within the countries. And again, for the most part, that's good. If we can increase adoption and keep children in the countries from which they were born or in the families that they were born to, that's always the best scenario. There's been some concerns, and we'll talk more about this, about the welfare of adoptees that are being adopted into other countries and negative perceptions about intercountry adoption due to some real and some imagined abuses. So like I said before, one of the trends is that Korea is no longer one of the major sending countries, although they do participate still. And that trend means that now the majority of children come from institutional and orphanage care, which is a vastly different setting to be raised in versus foster care or a home setting. Korea, for instance, started reducing the number of children available. And in 2008, I met with them, and they had a plan to end all intercountry adoption by 2011. They still say that they are reducing the numbers by 10% every year, but there still remain thousands of children available for adoption in Korea who are now being raised in institutional care. And that's, again, partly because of pressure from outside influences that say that it's better to be raised in institutional care without a family than it is to be sent overseas to become part of a family, which I don't agree with. Guatemala had also as you can see here, it was the top country for numbers of adoptions to the USA by 2008. But then in 2008, on September 12th, the Department of State issued an advisory for parents not to proceed with any further Guatemalan adoptions until the Hague standards were met in Guatemala. And so Guatemala is essentially closed to adoption at this point, and we're not sure if it's going to open up. Again, there are some reasons for this. There were some documented cases of child trafficking within Guatemala, and some tragic cases both for the parents who, the birth family, as well as families who had adopted children who've had to actually return their children after years of having them in their family back to families in Guatemala, which is a poor outcome for everyone involved. So they want to put standards in place so that child trafficking doesn't occur, and so that, obviously these things don't happen again. Ethiopia had the second highest numbers coming to the USA by 2011. We saw a lot of Ethiopian children coming over, and for the most part, were doing very well in their families, very healthy. But again, March 8th of 2011, Department of State issued the statement that prospective adoptive parents and parents awaiting final approval of their match from the Ministry of Women, Children, and Youth Affairs, they're cautioned to anticipate continued and considerable delays, encouraged to remain in contact with their agency for updates to their case. And this was again because Ethiopia decided to greatly decrease the number of children that they allowed for intercountry adoption. And we met with actually one of the ministry officials here in Minnesota who came through to ask us about adoption and whether it should continue, because he had recently visited this home after this 13-year-old Hannah Williams died of hypothermia and malnutrition in her backyard. Her parents had written or were inspired by this book to train up a child. It encourages children to be biblically punished, and she'd been basically tied up in her backyard and died of hypothermia and malnutrition. And so, clearly to Ethiopia, that makes it look like it's not safe to send their children to the U.S., so they've not closed entirely, but they've decreased by about 90% the number of children that they're allowing to come at this point. And again, we don't want these abuses to happen, but abuses and bad parenting, unfortunately, happens whether you're in a biological household or an adoptive household. And if you really look statistically at the numbers, there are far fewer children in adoptive homes who, suffer at the hands of kind of this kind of parenting. And so the outcomes here are that children are ending up in institutional care in their home countries and not being allowed to join families. China as well has reduced their numbers by about 2/3 since 2005. The result of this is that it's almost exclusively special needs, or what they call waiting children, that are coming for adoption now to the U.S. from China. Part of this is there's more domestic adoption happening in China, which is a great thing. There's somewhat less pressure of that one-child policy. If you adopt in China, it doesn't count towards the one-child policy. So you can have a biological child and adopt, and it doesn't count against that pretty strict policy that had been historically. But China, interestingly, almost entirely will not adopt any special needs children. And these can be, a child who has some mangled fingers from amniotic band sequence, or, has some very minor, but quote-unquote special needs, but still there's a huge emphasis on physical perfection within a lot of Chinese households. And so the kids that are in the adoption system typically have some sort of obvious or physical manifestation that makes them into the waiting child or special needs program. I think probably all of us, or hopefully all of us, have heard about this case a couple of years ago. Artyom Savilyev, he was a 7-year-old adopted into a single-parent household, and his adoptive mother put him on a plane with a note taped to his chest that said, basically, I don't want him, I can't care for him, and send him to Russia. And she had arranged somewhat for someone to meet him there, but she basically terminated her own parental rights by putting him on a plane and sending him to another country. And this caused great uproar both in the U.S. and in Russia, because Russia felt, again, if this is happening to our children, then we can't send any more children. They also have not closed entirely, but they've decreased their numbers quite a bit. And but again, some good outcomes out of this. So July 31st of 2012, President Putin signed an agreement that basically put additional safeguards in place, more information pre and post adoption between families and agencies, and they are encouraging more domestic adoption in Russia, although again, children who have risk factors in their background, like a birth mother who had hepatitis C, for instance, will typically not be adopted within Russia because they're considered special needs, even if they're not infected. So who are the children that are really coming home? And I just put this slide up because it seems like every day a celebrity is adopting, and we think that this is what adoption is internationally, and it really isn't. This happens, but if one of the residents wants to take a stab. So celebrity daughter, what country, and who is the celebrity? Anybody? Who's the celebrity who adopted this little girl? Really? No, nobody. So Mercy James. Madonna. So Madonna adopted her from Malawi, which basically doesn't allow intercountry adoption. So this is what I mean. We see these cases that come and we think, oh, isn't that nice? But there are a lot of standards and safeguards that celebrities have managed to bypass. So this really is not, this is a face of international adoption, but it's certainly not the face of what we're seeing for internationally adopted children. So I just wanted to give you a few cases of kids and examples of what we do in our clinic. One of the things that my main jobs is to talk to parents and families who are considering adoption, talk to them about special needs. That sometimes I run through a 50-question checklist of all the different potential special needs they may encounter. In a nutshell, what does it encompass? What can they expect? And then once parents get a referral, they send information to us to review, look and see, do they have microcephaly? Do we think this is a healthy child as reported, or do we think they have McCune-Albright syndrome, or different other medical issues, and just talk to the parents. And it's not my job to tell them whether to adopt or not. It's just my job to inform them of what they're really looking at if they decide to make this child part of their family. So this little girl, XM, was a 12-month-old female, and the translations are always interesting sometimes from countries, but she wasn't known before admission to the institute, but on admission the skin on her right leg had diabrosis and a scar with part of blood. Otherwise, her development was normal. And they just described on this that her skin had, on the right leg, had a scar, part of, and it literally said illegible, for 5 by 5 centimeters. Otherwise, physical exam totally normal at 12 months old. So this sounds like a kid who had a scar from something before she came into this institute and now is doing well. So this was her referral picture, very cute little girl, had this scar on her right leg as described. And I talked to the parents, and, because of the medical information we had at the time, we thought maybe she'd been burned or in an accident prior to her institutional care, and the parents proceeded. Well, 4 months later, I got a very scared and frightened call from the parents because they went to pick her up, and this is what her whole body was covered with, which was not what was described in these records. Anyone want to take a guess at a differential here? Chronic granulomatous disease? Could be. Anything else? Well, we considered a few, pemphigus, but it's rare in children, especially this age. It is usually severe and affects the whole body, which it was for her, but a lot of times autoimmune, so develops in more adult or teenage years. Derriere, nail, skin, mucous membrane changes. She didn't have nail or mucous membrane changes necessarily, and epidermolysis bullosa. And she came home and she was diagnosed with epidermolysis bullosa. And I did speak to PedsDerm while they were still in country, and I said to them, I know you're invested in this little girl, and she's beautiful and she may do well with you, but we think this is what she has at this point, and it is up to you at this point to decide whether you feel like you can care for her. And they said we can do it. So they came home, and they have seen a number of specialists here at the University of Minnesota. And this is her today. She's amazing. She's a beautiful little girl. You can see here that she still is bandaged a lot of the time. She does still have problems with her skin integrity because of EB, but she is thriving and doing beautifully. Just had to see a lot of medical specialists here at the university, and hers is not so severe that she probably won't be in the bone marrow transplant program. All right, so this is another little girl that we saw, 10-year-old female from Haiti. She was adopted from Haiti along with an unrelated male from the same orphanage. And for us, that's always it happens a lot. It can sometimes be concerning to adopt multiple children at the same time, especially if they're not siblings, because one inevitably has more issues than the other. And the other still has some issues that ideally would be addressed, but often get ignored because ones are so great, the needs are so great that the other gets a little bit left behind. So this is always a little bit tricky when you have two kids, especially when one, and this FC had a lot of her own things going on. The adoptive family already had 6 biological children. It was a stay-at-home mom and a full-time employed father. They'd had very little to no counseling prior to adopting these 2 children. It was more of a church-based faith initiative through their church that they decided to adopt. She had been raised in orphanage care since infancy. Her orphanage collapsed in Haiti during the earthquake. She was moved to a temporary shelter that I found out later had also been used as hospice. So she was surrounded by dying children and adults in this temporary shelter. Then she moved to a coastal orphanage. Then she moved to one last orphanage. That was the functioning hospice center until she had joined her family in the USA. So this is a little girl since infancy, had been in multiple placements, never knew a family, never knew a home, multiple transitions, and was at very high risk to begin with. She had a history of severe malnutrition when she entered orphanage care. She had no functional language in Haiti. She'd never been to school, and she had congenital deafness. She came home, and she had a lot of outbursts and a lot of behavioral problems with this family. Additionally, and on my last slide, I said she had a number of minor medical issues, and really, she had a lot going on, but these things are addressable, and medically, we can take care of these things. It was the behavioral problems that were outstanding, and yet these may somewhat be contributing to it as well. She had latent TB, she had microcytic anemia, she had vitamin D deficiency, she had multiple parasites, global developmental delays, and precocious and accelerated puberty. So she had a lot of medical needs that we needed to address when she first came home. And then we also needed to address her behavioral needs as well. So we had set her up. We have a pediatric psychologist, Dr. Maria Krupina, that we work with as well, who's really wonderful with these families and helps give them a direction. And so we had set that up. But there were some emergency discussions because she assaulted one of the other children in their home. There were 7 other children in that household. She didn't have any language and was deaf. And, these behavioral outbursts became not manageable for the family. So she went into inpatient, and it went extremely well. She started communicating with sign language interpreters who were teaching her how to communicate for the very first time. She was behaviorally doing beautifully because she could actually communicate with someone for the first time. But then the adoptive mother refused placement back in the home after the inpatient stay because she was too afraid about the safety of the other children and about her ability to manage this little girl. So they arranged for a family in the church community to take her. This family had 4 biological children and 3 adopted, including one with severe spina bifida. And she moved into that household. And these, my point in telling you this is because not only did this little girl have some infectious disease or medical issues, she also had emotional behavioral needs. And then we also deal with very complex social situations when families are trying to make a good decision, and yet there are, it's difficult to make a good solution for some of these children with severe needs. Basically, the government found out that she'd been placed without, there needs to be screening and social work involvement if another family is going to actually adopt this child, and they had not gone through those routes. So this little girl was removed from that home and sent to a center in Florida, actually. So another transition for her. So ideally, families will have a lot more preparation prior to adopting these children and know get some sign language in place before she comes home and prepare themselves so that you don't have a child coming home that can't communicate at all and have really no recourse. So unfortunately, this was not a great outcome for that family. On a slightly brighter note, this is JS. He was a 27-month-old male from Korea who is developmentally advanced for age. And just as an example of what we do besides pre-adoption counseling, seeing these children when they come home, we do advocacy work in other countries. And I had gone to Korea to speak with the Ministry of Health and Welfare. And while I was there, one of the agencies said, "There's a little boy. He's amazing, but we don't know what to do with him because something's wrong and we don't know what it is." So I went to go see him, and he was amazing, as they said. But he was missing his right thumb. He had a rudimentary kind of floating left thumb, dysmorphic facial features, low-set ears, right facial palsy, right hydronephrosis. He was very small. He had failure to thrive for height and weight, and yet his head was totally normal, which is why he looks like a little lollipop. And he had this cafe au lait on his left leg. So again, any of the residents, if you're missing your thumbs, what else do you think you're missing? Anybody? So, yes, so he didn't have any radii. He had absent radii. So that's one of the big clues when you don't have your radii, that we need to look for something pretty significant, because it doesn't happen very often that your thumbs are involved. Anybody know what he has, or what did you say? He has Fanconi's. So we had a differential diagnosis, but none of them really fit for him. And I actually worked with some genetic counselors here who were wonderful and helped direct the genetic testing from Korea. And he was confirmed to have Fanconi's. I'm using his photos and information with permission from the family. They do get care here at the University of Minnesota, and he'll be transplanted here as well. Fanconi's, just really briefly, DNA cross-linkage breaks, and the testing that we sent off was for MMC and DEB. It causes bone marrow failure, leukemia, and tumors. And the median diagnosis is 7 years old. So we were a little ahead of it, but he had some pretty significant clues that something was going on. This is him now. He came and had his first appointment here at the University of Minnesota this past winter, and his family contacted me because they knew that he had a really special place in my heart. And we had lunch, and the mom looked at me and she said, "He is everything you said he was," because he is really amazing. His older brother, this is his family, taught him how to do a model face, so that's his model face. So he's doing wonderfully in his family, and he would not have been transplanted in Korea. And so it's great that he's found a family here and will be. So just a little bit of research. I just wanted to touch on a few things that are going on here at the U of M. So the International Adoption Project, it was the International Adoption Clinic at the U of M and the Department of Human Services. They looked at internationally adopted children whose decrees were finalized in the state of Minnesota between 1990 and 1998. It was a very large survey. There were about 2,300 children in this survey in about 1,800 different families. And again, kind of looking at the 90s, what were parents concerned about? Well, they were concerned about medical and behavioral, but a lot of times the thing that scares parents the most is tuberculosis or HIV. And those are some of the things that we have treatments and cures for. But the pendulum, so like I said, the pendulum used to be around these infectious disease issues. And then for the last 10 to 20 years, we've started to note a lot of concerns about these kids who are coming from institutional care and are neglected and have abuse in their history and multiple transitions. Now the pendulum is beginning to swing back a little bit towards medical because of, like the cases that I showed you, a lot of kids with these special needs and medical issues that are coming home. So a little bit of both now. So again, just some results from this study, that height was stunted, vision problems, speech problems, and we'll talk a little bit more in depth about these, and some infectious issues as well as vitamin and lead issues as well. Vision is one of the things that I'll talk about a little bit more, but there were a lot of documented issues with strabismus, farsightedness, astigmatism, nearsightedness, and so we refer children for ophthalmological exams when they come home. Hearing loss and ear infections as well, a lot of ear infections in that first year post-arrival, and a lot of hearing loss, and much of that not known prior to them coming home. So good to get them screened when they come home, especially since they are not part of the newborn program that, you know, every infant is screened in this hospital before they leave the building, and referred if they, you know, even have a question of hearing issue. They don't have that. So when they come home, you know, we have them screened officially for their hearing needs as well. Speech and language problems, most common problem was articulation and general speech delays. So we refer and screen these kids for different therapeutic needs. And then another study done by Anita Fugelstad as her thesis here with Dr. Georgieff and a number of other doctors here is on micronutrient deficiencies. And this is interesting because we didn't used to screen for these, and now in the screening protocol, I'll show you a little bit more about this. But they found a large number of these children with iron, zinc, and vitamin D deficiencies that we weren't aware of before. Vitamin D has been a pretty hot topic in general in pediatrics, but we were also finding in this population that they were certainly deficient when they came home. Another issue for them, and some more research that's going on, I think Dr. Miller and the Peds endocrinology team here are particularly interested in this. Precocious puberty, because these children are so stressed and so growth stunted in their orphanage care or in their settings prior to adoption, when they come, it's kind of like the floodgates open up. They're happy, they're loved, and their hormones can finally act as they should, except sometimes they overreact a little. And we see kids, especially little girls, who hit precocious puberty and start developing very early. And not only do they start early, but they go through it very quickly. So these are some of the studies that have been done with that. And like I said, Dr. Miller is particularly interested in this and has been seeing our children for this. Another small project that I did was just to examine the differences in referrals between 1998 and 2008 to see how they've changed. We'll just run through this quickly. I used Korea to highlight some of the changes because Korea had been considered the model country of, foster care, good care. These children were loved and fed before they were adopted. And yet, even in Korea, which is the model country, there have been a lot of changes. One is that they're getting older, and this is a trend we're seeing from every country. There are a few reasons for this from Korea, including a law that had basically taken place to not allow children to come early, to give them time to be domestically adopted. In theory, it was a good theory. In practice, it has not been successful, so now they're just coming over later, and it makes it more difficult for them to bond if they're much older by the time they get here. Tobacco use, and I went to Korea for the first time. I'm a Korean adoptee. I went back to Korea back in 1998. It was my first trip, and it was really interesting to me coming from the college in the U.S. because women there did not drink. If you drank, you had to turn your head to the side and cover your mouth. They did not smoke. I had a friend on my trip who was a smoker, and she got chased down on a street because an older man was so disgusted that she was actually smoking. And everyone was very modest. And it's changed quite a bit in 10 years until you can see the change from the amount of people smoking back in 1998 on these referrals to the number in 2008. It's been a huge shift in the young women there. And China is following that trend as well, unfortunately. A lot more, so just tobacco linked with low birth weight, cognitive behavioral problems, lower intelligence, ADHD with or without hyperactivity, and that's from the AAP policy statement on prenatal tobacco exposure. In general, there were just more medical problems, and for this purposes, I'm not going to go through all of them, but there were just more listed and known medical issues with these kids. Syphilis was increased as well. I had a small n, so it was 0 to 2, but we definitely have seen this both from Korea and starting in China. They made prostitution illegal in Korea about 3 to 4 years ago, and so none of the prostitutes are getting tested anymore or treated. And so syphilis in the last 3 to 4 years has unfortunately gone a little wild in Korea. And then also, this is just a study talking about China. It's happening there as well. One of the biggest things in my research interest is fetal alcohol spectrum disorder, and alcohol has definitely increased from 1998 to 2008. And having been in Korea a lot, the ministry there does not really think that it's a problem for young women to drink. They actually said to Dana at one point, but our women eat appetizers when they drink, so it's fine. And so there's not this knowledge that it's probably detrimental to drink during pregnancy. So the women there are pretty truthful, and they'll report, I had a half bottle of Jack Daniels every day for my pregnancy, because there's no reason for them to lie. They don't think that it's wrong at this point. So we've seen a lot of young women that are drinking during their pregnancy and exposing children to alcohol. And, like I said, when I went there, you weren't even allowed to wear shorts. And now we have ads like this, where celebrities are promoting, this is basically the Korean vodka, and how fun and young and sexy it is to drink. So young women are really, have taken up this and are drinking far more than they ever were back even 10 years ago. So just in the last amount of time we have, I'm going to run through this section pretty quickly because you're always welcome to come to our website and look up. We have the screening and recommendations there. But I just wanted to highlight some of the main questions that we get. The Yellow Book basically in 2008 put out that the evaluation should be done within 2 weeks of the child's coming home to the U.S. and what those recommended screening tests were. So we see the children in clinic 2 to 3 weeks post-arrival. We review medical history for the birth family as well as the child, infectious disease screening in country. And then we have a developmental specialist, either an OT or a PT, who helps us screen the child for speech, OT, PT needs, and help develop some home programs for the families to do as well with the children. Because most children catch up in their homes with good parental guidance and some home programs. And we look closely at attachment, indiscriminate behaviors, and bonding, and we do some counseling with the families to help promote the healthy attachment in the first 6 months home. This is a list of the screening, and again, I'm not going to go through all of this for time, but I'll highlight some of the ones that I get a lot of questions about from the general pediatricians in the community. So tuberculosis is always a big question, and what do we do with a kid for tuberculosis screening? Well, you can do a TB Mantoux skin test, the PPD, and that's still perfectly acceptable in any age range. We also, though, have a quantiferin gold blood test that's now approved for children over 5 years old, and so we can send that as just part of their general screening, which helps a lot in these older kids because parents don't have to come back for that second check, which we lose some parents to follow up. It's, the placement of the PPD is important in terms of it reading out correctly. So it's been very helpful to have this quantiferin gold blood test. People also say, well, what if they have a BCG? What if they got the vaccination for TB? Can we still do the testing? And you can. As long as it's not an open, fresh wound from that BCG vaccination, you can test, and it still should be accurate with the TB test or the quantiferin gold, either one. If the TB skin test reads 10 millimeters or greater, then it's positive. I'll show you one of the tests here, but we see latent TB very frequently. We see active TB very infrequently. So I always tell parents that it might happen and to stay calm. I've had community physicians call me and say, it's positive, and they shut down the school and they close the clinic and they're evacuating the city. And so you don't need to do that. We just need a chest x-ray because most of these kids, especially the younger kids, are not infectious even if it were to be active. And obviously, if it is, we do a chest x-ray to evaluate for active TB. If it is active, then we would usually admit them and try to evaluate to get an organism. So we talked about BCG. And this is a paper from 2008 that just talked about the fact that we do screening initially 2 to 3 weeks after arrival. We see them also at 6 months post-adoption to finalize the screening, which includes a second TB screen at that point, because they found that about 20% of kids who had been negative initially were actually positive by the second time around. And this is with PPD TB skin testing. And there are a number of reasons for that, including the stress of the child, again, the placement of the PPD correctly or incorrectly, and getting a false result in the end. But by the second time around, a fifth of the children who were actually positive were picked up by that time, which highlights the importance of the repeat screening. Stools, we always send 3 stool OMPs and 1 Giardia specific antigen. And we test them 3 times because you can shed at different times, and we pick up closer to 98% by the 3rd stool sample, but only around 75% with the single stool OMP. And I would say, again, many of our kids have a positive stool result even if they don't have diarrhea or constipation. So even if they're asymptomatic, we do recommend for screening on all children. And again, just up to 33% have ovarian parasites, some sort of parasite identified on their stool testing. Immunizations, we get this question a lot. What do we do with their immunizations? Well, technically, the official party line is that you can take any documented and correctly timed vaccination as correct and proceed from there. However, we do titers, and there are a few reasons for this that I'll highlight here. We check diphtheria, tetanus, polio, chickenpox, MMR, Hib. And why do we do titers? Well, here's one paper that basically showed that the immunity rates for different, so China was especially bad, and then other countries. But even other countries, the best we could see is somewhere in the 80% immunity to tetanus. Diphtheria was still around 65, 70%. China was, in the 30s for some of their immunization rates when you looked at titers. So we do recommend checking titers, and if the child is not immune by titers, to restart that or do a catch-up vaccine schedule for that child. So again, another paper just saying that, in the 50s, 60s, in this study, it was diphtheria tetanus found to be 91.4, but some of the others were pretty low, and that's a big percentage of kids to not be vaccinated if we just took their records as valid. Hearing and screening, we talked a little bit about this, but just we've done a number of projects and even follow-up projects from their initial international adoption project that showed that kids have risks for vision and hearing problems, and most of them have not been diagnosed prior to coming to this country, so a formal audiology and ophthalmology exam. A lot of premature, low birth weight children that are coming from other countries, which contribute to some of these vision issues. And then speech delays, because speech delays are so common, the first thing that you should think of is to have a hearing test to make sure they can hear, and so that if they're getting speech therapy, they can proceed and be successful. And then this is just a list of the 6 months post-adoption visit, why we see them again at 6 months. Besides the PPD or the repeat tuberculosis screening, we are screening to make sure that they weren't exposed to some of the infectious diseases prior to leaving their country. We also look again at developmental progress with our OTPT, and we look at attachment and other bonding issues to see if they may benefit from further help from our team. So just in the last minutes, a little bit about advocacy. And Dana Johnson has done a large amount of advocacy in many countries because he is so well known for this field. And some of these are from his travels and some from mine. And I had a video that I wanted to play for you, but won't load here, so I'll just describe it. My trip to China was interesting because these kids, this is actually a fairly decent Chinese orphanage, and you can see the cribs are just kind of lined up, and children are left in there for most of the day. The orphanage system that I went to, and this was part of the video that I had. Children were 5 in a crib, all with major special needs. And the video that I had, I took just a couple, 30-second video, and there were children with flies on their faces and children rocking in their cribs because they were self-stimulating, because they had nothing and no one to pick them up or play with them. And this is how they spend their days. So this, again, many children are coming for adoption, but the numbers are decreasing. And so most of the children these days will be left in these orphanage systems. And so what can we do to improve the lives of those children, which are many more than the children who eventually find a home? This was one little boy that I just was walking by a window, and he didn't call out to me, didn't say anything, because I think at some point a lot of them give up, which is very sad. This is a little boy that I examined there. I'm not sure what his diagnosis is. He was very hypotonic. He didn't move. He smiled a little bit, but he was about 2 years old and in one of those cribs with the 5 other kids, and he had a pretty clear bite mark from one of the other children on his face and probably couldn't defend himself very well because he doesn't move very well. So what can we do about this? So part of my purpose on that trip was not only to evaluate children who could be adopted into homes, but also help the children there to have better outcomes and better lives there. For instance, they had newborn babies that would be dropped off at their orphanage almost on a daily basis. There were some even in the short time that I was there, brand new, 1 day, 2 day old babies. And they were feeding these infants every 8 hours, 8 ounces of formula with bottle propping. And they were saying, and they throw up. We don't know why they throw up. And I was thinking, you're giving a newborn baby 8 ounces and you're feeding them every 8 hours is just, it's unheard of. So I basically started a policy that said anyone under 2 months of age has to be fed every 3 hours. And we got a volunteer program going there to come in and help feed the babies. And they said, oh, but if we get volunteers in here, then maybe the babies are going to bond with them and then that'll be bad. And I said, but it's probably better for them to, granted, yes, we don't want them to bond to lots of people and then have them leave, but better than bottle propping and only being fed every 8 hours. So, we got some volunteers in there. There are granny programs where retired people in the community can come in, help hold the babies, talk to them, feed them. And then we had a physical therapist with us who also instituted some physical therapy exercises. Especially, there are a lot of kids with cerebral palsy in this orphanage and hypertonic limbs and joints. So she started a program with balls and mats and getting them out. We said every child has to be out of their crib twice a day, every day. And they were shocked. You know, really? Twice a day? A child has to? Because most of these kids are in their cribs 24 hours a day. So we hopefully, you know, it's small steps. That's not obviously an ideal thing, is just 2 times a day, but it's kind of small steps. And so we're trying to get into some of these orphanage systems and institute change a little bit at a time. The other thing with Korea, again, it's advocacy, and it's something that I get a little frustrated with, and yet I still try to do it with the examples of some of my mentors before me, because it's a lot of politics. You go and you talk to people, and you hopefully institute some change. Like at the Ministry of Health and Welfare for Korea, I go once a year and talk to the Minister of Health and Welfare about orphans and about adoption, and about adoption works as a last option. We would always prefer that they stay in their birth families, and if not that, then they be able to be adopted in their home country, and if not that, then allowing for intercountry adoption. But that long-term foster care and permanent orphanage care is not the answer for these children in order for them to be successful once they, you know, age out of those institutions and they get $2,000 and a good luck. So we're hoping that they will continue to listen to us, because they're hearing a lot of other advocates who say that adoption does not work. Some adoptees who've had very poor home situations in their adoptive families. And I get that they were hurt and scarred by their adoptive families, and yet to close adoption to, you know, all adoption, I don't think is the answer. So there are different organizations. One is Mission to Promote Adoption in Korea, which also just advocates on the behalf of orphans and adoptees. It's run by a Korean adoptee who was adopted as a handicapped 13-year-old in an orphanage off of the street kid, and miraculously found his way to the U.S. And they thought he was, you know, physically and mentally handicapped, and he's now a aerospace engineer and does satellite technology for NASA. And so Korea has been very interested in listening to him and tell his story and help to advocate for other children to have a chance like he did. There's Red Thread and Half the Sky, and these are organizations that are also, especially Half the Sky is getting into these orphanage systems on a system level and trying to institute major changes in the orphanages, and Dana's on the board for them. And then there's a Worldwide Orphans Foundation, and this is much more than I can talk about in this short time, but they're run by another international adoption pediatrician out in New York City, who's frequently in People magazine because she does help with like the Angelina Jolie and the celebrity adoptions a lot of the times. But she's managed to turn this into a real foundation, and she's doing things in the communities, community-based healthcare, mentoring and training programs. So again, the pediatricians, the community workers, the volunteers can all be involved in helping these kids who are still in the orphanage system in the countries that they're in. She's created Orphan Rangers, which are anyone from a student to social worker to doctor who basically go into these programs with different missions, toy libraries so that kids have things to play with, one-on-one programs, again, like the Granny program, to come in and just love these kids and give them some attention. And I just wanted, lastly, to thank my mentors and the Division of Global Health for their encouragement. Cindy Howard's my partner there in international adoption, and Dana Johnson has kind of led the way and helped me to find my way to international adoption. And Chandy John here has really supported us as the head of our division. So I'm happy to take any questions that you have. Thank you very much for your attention.
And I think that your example of that family who, you know, through their church said, oh, yes, we want to do this. They had no clue clearly about what they were getting into. And I think that, you know, part of the politics is to really show that the system here, the screening system or more than it doesn't work.
Yeah.
And so maybe can you talk about that a little bit?
Yeah. So she's asking about the screening process for families who are adopting, and I totally agree that one of the biggest hurdles for this is the agencies, because you can have, and in the past there were many of these kind of mom and pop agencies who had connections in a country and were facilitating adoptions kind of on a private basis almost, who had no resources for follow-up or post-adoption services, or if a disruption happened. And that was a big problem. We called the head of the agency for this particular young woman, and she was not excited to hear from us, and she was clearly doing dishes in the background while we were talking to her. So, during a work week, and so her help was not great when we, were trying to figure out what to do with this little girl from Haiti. One of the things that's happened is with the Hague policy starting to be institutionalized across the board, is that these agencies have much higher standards in order to participate in intercountry adoption, which is consolidating and basically eliminating a lot more of these kind of mom and pop shops because they don't have the resources to get through all of the legal hoops that they'll need to for the Hague. And I met with the State Department just about a month ago and talked to the Children's Ambassador for Children's Affairs, and they're doing a lot in terms of instituting new standardized policies for agencies in order for people to be able to adopt, and for adoption agencies to allow them to adopt. And I think, nothing's ever a perfect system, but I think that that's actually going to help a lot with some of these kind of, undercover adoptions that aren't being supported very well.
So are these, most of those, is there licensing for those agencies? Because, it seems like, obviously, even nonprofit organizations have to make money to support their staff. But, if you're a for-profit, I'm just wondering about that sort of piece of it.
Yeah, there is licensing to be an agency and to be a licensed social worker in order to facilitate some of these adoptions, but the bars are not very high, or not any higher for international adoptions in the past. With the Hague, that is changing because there are now international standards that people are going to have to be held to. And again, I think that is going to change this. Yeah, Nimi.
Judy, I was wondering, can you say a little bit more about how many programs are there like this in your country? What's your workload? Do you guys end up seeing a lot of families from all over the country, or is it mostly the West?
So she's asking how many programs are like us, the International Adoption Clinic. I would say, and please correct me if I'm wrong, I would say there are about 4 large programs similar to us in the country that have a few physicians that are doing what we do. I would say there are another probably 5 or 6 that are very involved and know what they're doing and just see a much smaller volume. And then there are another 10 to 15 to 20 that are basically still doing just the infectious disease screening and not much else. So haven't really evolved past kind of the do they have HIV and do they have hepatitis. For a long time, I think we've considered ourselves to be probably the highest volume, largest adoption clinic in the country, which is one of the reasons why I came here, because Dana Johnson has done so much work and is very well known. We have an upload system to review files or to talk to parents that is online. So we routinely work with families all over the country, all over the world. I had a Skype call with a family in Spain the other day who wanted to know, more information about this child that they're considering adopting. And we currently operate on a donation basis where the families donate for our time and our effort, and in exchange, we answer questions and are there for them and help them through their traveling. Yeah. Any other questions? Thank you very much.